My name is Saul Pressner, and I'm the current president of the ABD, as Matt mentioned, and I practice biomimetic dentistry in New York City. It's my deep, deep pleasure to introduce Dr. Melissa Seibert today, and she's a dear friend and colleague, and she'll be speaking today about minimally invasive caries removal, as Matt mentioned. So take it away, Melissa. Thank you.
Hey everybody, thank you so much for coming out on this afternoon. Saul, thank you so much. I'm really grateful to the Academy of Biomedical Dentistry. If I may, I'm going to go ahead and share my screen so that we can share my presentation. Matt, I trust that you'll let me know if things aren't showing up correctly. But what I'm going to be presenting on in this relatively brief presentation this afternoon is going to be on minimally invasive caries approach. What I created, and I verify with Saul it's okay that I shared this. What I'm going to be actually doing this afternoon is giving you a sneak peek to a presentation I'm giving in Journal Club. So what I did is I created this thing called Elevated GP. It's at theelevatedgp.com, and here's a QR code. And what this is on-demand content related to anything in minimally invasive dentistry, restorative dentistry, comprehensive dentistry. And then we meet once a month for our once monthly study club where we talk about hot topics in dentistry. So what we're actually going to spend the majority of this presentation talking about is the Schwinn-Dickey article that came out not too long ago in 2015. And this is a hot paper. There are a lot of topics to unpack here. So what this is this was effectively a summary from the International Caries Consensus Collaboration that was held in Leuven, Belgium. What is the actual dental caries process? Well, first of all, we know that the mouth, this is effectively an extension of just basically the GI tract. And just like the GI tract has healthy normal flora that should exist, it's the same thing with the oral cavity. There is normal flora that should exist, and we don't want to remove this. We just want a healthy sort of balance, a healthy stasis. And in fact, we've evolved to have this bacteria in our mouth. So this is another reason why we don't necessarily just want to be constantly exposing our GI tract or oral cavity to antibiotics, anything that's going to really just kill off all of that healthy bacteria. Just as I previously alluded to, the reason that this is problematic is, again, the biofilm is going to switch and it's going to change its profile. And now this is going to favor demineralization rather than remineralization. As many people have kind of learned in dental school, as you're ingesting food throughout the day, there's just kind of an ongoing constant tug of war between demineralization and remineralization. And when we see this demineralization sort of being more favored, where it's a lot more frequent, this is then where we see much more breakdown of the tooth structure. Ultimately, what's happening is that in the oral cavity, it's an acidic type of environment, and really in the tooth's capacity to buffer this acidic environment, calcium and phosphate are being leached out of the tooth. That's ultimately helping to neutralize the acids, but then as a result, because they're being leached out of the tooth, now the tooth is being demineralized, it's much more porous, and ultimately, if this process continues, this is where we see tooth structure being lost. So can we actually cure caries? You know, maybe when I first entered dental school, I wondered if I'm actually going to have a job in 5 to 10 years. If they can just develop some sort of vaccine for caries, then I mean, most of us are really going to be out of a job, but that's just not the case. Because again, because this is really sort of a flora, that's the problem. It's not just one single species of bacteria, but rather this sort of conglomeration of bacteria that works together in tangent to create caries. We can't just readily cure it. And so what needs to actually happen is that the supply of fermentable carbohydrates and the biofilm need to be managed. That's actually how caries is going to be cured. And so this comes down to modifying diet and then constantly being able to remove this problematic biofilm. So oral hygiene effectively. So this right here, this is actually an example of a case that, to be honest with you, I beautifully executed the case. This was a really grossly broken down tooth. It was referred to me actually for extraction. I said, nope, I think we can save this. Well, actually, no, I think it was referred to me for the restoration. The dentist didn't feel comfortable doing it, but they knew that I was comfortable doing it. So what I did here, I elevated the margin, and then I did a occlusal onlay. It looked beautiful, but I didn't post on social media because I think I was concerned of receiving sort of backlash from my colleagues for my approach to this lesion. But this was actually a case where I knew that this lesion had arrested. It filled all the criteria. The lesion had arrested. It was firm. This is not active caries. Was firm to tactile sensation. This was a patient with a high dental IQ, young female, followed oral hygiene instructions. At one point, you can see that she had some active lesions. Actually, she had quite a few, but she really kind of got with the program. She followed oral hygiene instructions. So a lot of her existing lesions had demineralized. Um, she frequently followed up for recall visits so we could continue to monitor it. And it's in a location that I can visualize, I can monitor for activity. So it's checking all that boxes. It's visualizable. Patient has good dental IQ. Patient routinely follows up. And then it's in an accessible site for the patient. So I did not go after this lesion. And then this photo also illustrates a couple other important considerations. These dark spots right here, this is just sort of oxidative byproducts from old amalgams. People will often go ahead and take these away, but at that point, you are just unnecessarily removing tooth structure. You do not need to remove these. This is firm. This is healthy tooth structure. Let it be. So again, going back to the idea of Pitt and Fisher caries, we've really kind of talked about this. I'm not going to spend too much more time, but what the authors in the Schwindicke paper talk about is that for Pitt and Fisher caries, if the biofilm can't be managed, it is acceptable to go ahead and seal over the caries. Now, there's some debate over there if you do want to resect and remove away some of the caries tissue so you can create a good restoration and then go ahead and do the sealant. I would say that if the caries is arrested, and so let's say that this is hard, then in that case, it's actually appropriate to go ahead and just entirely seal over. But you need to talk to the patient about this because let's say that you do seal over, well, the lesion, the final restoration is going to appear a bit dark. And so if they go to a new office, that practitioner might think that that's actually just frank caries underneath and a poorly placed sealant, and they might remove it. One effect to watch out for with sealants, though, is if you place these relatively thin sealants and you're just sealing over a lesion like this, an arrested lesion, is because it's relatively thin and it has a low modulus of elasticity, it might create this trampoline effect where it's actually sort of bouncing and then it might delaminate. Or even worse, it'll just sort of partially delaminate and then caries can fill into the voids. So for that reason, I generally will actually be more inclined to use glass ionomer as my sealant material. It's not nearly as technique sensitive. You don't have to have a great seal the way you might with a resin modified type of material. And it does give off some fluoride. Now, it doesn't give off quite as much fluoride as people might think. In fact, it typically gives off the most fluoride when it's first placed, and then it has to be recharged.